the rest of the session. So just to introduce you what research is. Research is simply a systematic collection, analysis, and interpretation of a data, which is based on a certain question or a problem that we have in order to solve or give an answer to that question so that we can implement that result into practice and change or guide our clinical practice. Even it could be as a leader or as other healthcare professional field of studying healthcare profession. So every research starts with a question or a problem. And for that, we have to go through a number of processes, like developing a way to answer that question or problem, which should be credible and acceptable. So that means we have to develop a proposal, and then to implement that, we have to collect data in a systematic way, and we have to analyze it properly so that we can get, again, an acceptable and credible result, which should be interpreted in the context of the society that we have studied the research. And finally, the ultimate goal of research is to apply the result to practice. So this is where we start with the research with a simple question, and finally we want to apply it. So, but before applying our research findings, we have to make sure that that result is applicable in different scenarios or circumstances, and that it should be considered as an evidence. So how do we get from a simple question to evidence? That's the process that we're going to see briefly in today's webinar. We said every research starts with an observation. So we observe different things in our day-to-day clinical practice or as a leader, but every observation doesn't count equally or doesn't surprise us equally. When we come across an observation that's unique, we get interested and we want to understand about it. So research starts with a unique observation that given our work history, our clinical practice, that if we find something unique, that observation can be considered as a starting point for a research. So let me take you back to the discovery of the potential for hypercoagulability following OCP. So let's say that the first person who observed or who encountered a patient who has developed DVT while she's on OCP, but she has no other factors that could lead her to a hypercoagulable state. So this is a unique observation for that practitioner. So he took that unique observation into an evidence through different process. So how do we go from this simple observation into an evidence? So evidence simply means consistency of a finding that we get from our simple observation across time and place or person. So let's say this this practitioner believed that this woman developed DVT because of the OCP she's taking, because she has no any other behavioral or personal characteristics that could lead her to the development of DVT. So to prove that OCP is a causative agent or a potential risk factor for DVT, this finding has to be consistently recorded across different time span and across different population characteristics. So if we can prove that, then that finding can be taken as an evidence, and we can comfortably say that to our patients. If you're taking an OCP, you have a risk of encountering some hypercoagulable states. So you have to prevent it using these methods. And if you are already high risk for hypercoagulable state, you're not supposed to take OCP. So rather, we'll give you another contraceptive method. So these are the things that we comfortably communicate with our patients and that we study as an evidence in our medical books. So how do we get from observation to evidence? So when we have a single observation, we start with a very simple study, which in general, we call them original or primary studies. So the first study can start from a single or an observation of a unique event from a single or group of individuals. So when we observe something which is unique in a single patient or a group of individuals who present with similar unique phenomena, but something that's not well studied, then this study, when we present their characteristics, we can use that as a starting point to generate hypothesis, so that that hypothesis can be tested and either proved or disproved in a larger study. So can anybody tell me what this an observation based on a single or group of individuals? When you observe a single or a group of individuals with unique characters, we do study, right? So what do you call that type of study? I mean, most of you are, I think, clinicians, so I'm sure you're familiar with it. What do you call those studies? Thank you. Great. So I'm just trying to make sure you guys are following. Thank you so much. Wonderful. So the thing is, when we have these type of studies, what we get from a single or group of individuals observation is not a knowledge. Rather, these are a starting point for us to question the possible relationship between this exposure and that outcome. So with this understanding, with this new observation, we can generate a hypothesis, which we can further prove or disprove using larger studies, which includes large number of study participants, so that those findings can be generalizable to the larger group of population from which we obtained or recruited our study participants. So in these studies, we have a chance to build some little to strong knowledge based on the strengths of study design that we use. So as he said, in primary studies, where every observation starts with a single or group of individuals observation. So when we have a single patient with a unique character, we call it a case report. And when we have a group of individuals with similar presentation, but that is unique to these individuals, we call it a case series. So this is a case series. A typical example is how HIV was first discovered. It was discovered in 5 homosexual men. So these 5 men did not have any other risk factor to develop PCP, but they presented with PCP. So, and they were immune suppressed. So they further studied and why these young, otherwise healthy homosexual men happen to have PCP. So with that further study, HIV was discovered. So we start from case report, and then we can, if we can get further patients, we can have a case series, but these two are important in order to generate hypothesis for us to question the presence of relationship between one exposure and one outcome. So after we get large number of patients through different recruitment mechanism, we can start these large studies. These large studies are in general from cross-sectional up to experimental. And cross-sectional study is the weakest study compared to the other studies. As we go down the inverted pyramid, we get a more strong evidence from a single study. So someone who conducted an experimental study, particularly randomized controlled trial, which is the gold standard study design for a primary study, the level of evidence that we get, the level of knowledge that we can gather from that study increases. So we can get little information or a source of evidence from cross-sectional study, and as we go down the pyramid, we get stronger source of evidence from experimental studies. But I want you to understand that this doesn't mean that we have to be able to conduct experimental studies in every scenario. There are different issues that limit us from using the higher research, the higher designs, due to different ethical issues or patient characteristics issues or cost and so many other factors. So it doesn't mean choosing the most strong study design is always the best, considering our specific research design. So in general, these are study designs for primary study, and these primary studies are divided into 2. These up to from case report up to cohort, we call them observational studies, and the other is experimental study, as you can see. So even from the primary studies, whenever you conduct experimental study, as we said, your level of evidence contribution is higher than the observational studies. So if you're not familiar with it, these are the commonly used observational study designs in order of their strength and importance. So when we conduct a primary or original study, the level of evidence that we get varies with the study design. But in addition to that, there are different factors that affect the credibility of our result. The first one is sampling issue. So the sample size issue. We have to be able to include representative samples when we talk about the credibility of these studies, I'm talking about the larger studies. After we generate hypotheses from case report and case series, we conduct larger studies, starting from the cross-sectional up to the experimental study. So when we conduct these larger studies, there are different factors. Despite the strength of our study design, there are different factors that we should take into consideration to assess the credibility of results that we get from this study. So the first one is the representativeness of the studied population. So what we mean by representative sample is, in these studies, since they are large studies and we have large number of patients, we should be able to include a representative sample in our study, because the goal of these large studies is to generalize the finding from the sample to the source population from which we recruited the patients. Let's say we have a population of 10,000 and we have studied 500 patients. So these large studies aim is to infer about the characteristics of this 10,000 population based on the 500 population. So to give a representative generalization of the findings, we have to make sure that this sample is representative of this 10,000 source population. So one thing is we have to get adequate number of participants. To get adequate number of participants, we have to follow the sample size calculation principles. So each and every study design has its own sample size calculation principle and formulas. So we have to pick the proper sample size calculation formula, and we have to add the relevant statistical considerations so that we can get a representative or adequate sample size for our study. The other is we have to use a fair selection process. After we get our sample size using the proper sample size calculation formula, we have to make sure that these 500 participants are selected randomly from the 10,000 population. If we don't select them randomly, if we interfere in a way, some people are chance of being selected for some group of population is higher, then this is not representative. So what makes these studies acceptable is their representative nature, which is assured by a random selection from the source population. So we can use different sampling methods like simple random sampling, systematic, cluster, multi-stage, stratified, whatever, but these are probability sampling methods that we have to apply for our study. So the other is using proper study design or picking proper study design that fit our research question. Like I said, even if the strength of evidence that we get from our study designs, from our study increases as we go down our inverted pyramid, it doesn't mean that we always have to use a higher form of study designs due to different issues. Let's say if we want to study the effect of smoking on progression of some disease condition, for example, we can't make some group of patients smoke so that we can see its effect as compared to those who don't smoke, right? So the place for experimental study in exposures that are harmful, that are potentially harmful to the participant is 0 because of its ethical issues. So even if we get, even if we know that we can get better evidence, with experimental study, the best we can do is we use cohort study by recruiting those who already smoke and those who don't smoke, and by following them, we can see in the future if how many of them have a bad disease progression, and so that we can conclude smoking is bad for this disease progression. The other, on the other extreme is also a beneficial therapy under study. Let's say that we have developed a vaccine which is found to be useful even at a preliminary level. And if we don't have any other treatment options, and if we believe that the drug is better than not giving anything, the vaccine is better, then we can't deny that from some group of patients for the sake of study purpose. So as soon as we ascertain that that treatment or therapeutic option is better than not giving any other thing, then we have to stop our study and administer that for everyone, because the safety of our participants comes first than knowledge generation. So in both scenarios, we have to be able to choose the proper study design. And the other is if the presence of rare exposure and outcome also guides us whether to pick case control or cohort design. So whenever we have rare exposure, whenever we have rare exposure under study, let's say taking OCP is something rare that only very few people take it, then the best, DVT, I'm sorry. Let's say that DVT is a very rare circumstance. And if we have only very few patients with DVT, then the best we can do is start from patients with DVT. That means we have to conduct a case control study. On the other hand, if taking OCP is something rare, then we have to start recruiting our patients based on their history of taking OCP or not. So in that case, we have here, rare outcome. We have to start with the DVT. And in cohort, when we have rare exposure, that is when we have few patients taking OCP because of their limited number, we have to start by recruiting those limited number of participants and following them into the future to see if they have developed DVT or not. So all of these things guide us whether to choose cohort, a case control, or cross-sectional, and all other study design. So taking into consideration the research question and the available resource and the ethical issues and the nature of the variables under study, we have to select the proper study design. The third is after we collect our data, it's something that is usually overlooked. Data management is a very important part of our research. Unless we manage our data, we're going to end up comparing variables that should not be compared, and we end up comparing we end up with unfair comparison between participants that could lead to an obviously exaggerated association between our exposure and outcome. So data management is something that we should do, and there are different components of data management which you can further read on. And the other is picking the proper statistical tools. So usually we tend to select statistical tools that we're comfortable with or that we are familiar with, but research doesn't work that way. It's like for every disease condition, we have some therapeutic recommendation, and just like that, for every variable and for every data, we have a proper and suitable statistical summarization and analysis tools. So we should feel comfortable using the proper tools, and we should introduce ourselves to the commonly used tools in at least clinical research. So we have to make sure that we have to pick the proper statistical tools, like proper regression model, proper statistical test. Like if we have to use t-test, then we have to use t-test. Just because we don't know how to use t-test doesn't mean that we have to convert our data into some other categories and use chi-square test because we are familiar with it. So we have to pick the proper statistical tools whenever necessary. And every statistical tools that we use, like mean, median, chi-square, t-test, ANOVA, regression models, everything has their own assumption before using the test, and testing these assumptions is very critical. It's something as a reviewer of medical journals, this is something that I encounter, like, I don't know, 97% of the time. Most of these researchers, they don't test assumptions for the statistical tools they picked. They just dive into using them before testing the assumptions of these tools for their data. So it's very critical. It's like when you forget to test assumption of the tool that you picked, it means, let's say, you have a patient whose clinical presentation seems like appendicitis, you do ultrasound, you confirm that, and then you just don't take the patient into the OR. You have to make sure that the patient is like stable enough and can undergo a surgery, right? Like unless we confirm that, just because the patient has appendicitis, we just don't dive into the surgery. We have to ascertain some parameters are fit so that the patient is suitable and eligible for the operation. So it's like that. Consider your data as a patient. You selected some form of therapy. Let's say for that data, that therapy is not a good idea because of the nature of the data. So we have to switch to another form of statistical tool. So it's like that, and testing assumptions is very important, and don't take it for granted. The other is after we get our results, we are responsible to interpret it in an accurate way. When you think about it, if you have your result table, a researcher can read into the tables and see and interpret the results for himself. But for most of our clinicians, that might not be the case. We want someone to accurately interpret the results and put it in a way that we can understand because of our limited research exposure due to our curriculum and due to different things. And in addition to that, even patients can read our journals, right? A diabetic patient might be interested in the new developments, and they might open a journal and read about the new research findings in DM. So as an author, we're responsible to provide accurate interpretation of our results without exaggerating it or underestimating the findings. And we have to further contextualize the results into the setup that we have studied. We have recruited the patients so that these results can be used in the context of what we have found. And the last one is we have to give realistic or result-driven recommendation. Usually our recommendation way exceeds our the true finding that we have. So that should not be the case. Recommendation has to be result-driven, and it should be within the context of what we have truly found and in the context of the meaningful results that we should contextualize our findings. So you might wonder how to assess these things, but fortunately, there are different tools that we can use to assess if a primary or original study has included all the relevant things in its manuscript. We can also use these tools to assess our own manuscripts or even our own proposal or thesis reports, which we're doing for a program fulfillment at schools. So these are there are different tools, and among this, I don't know if you're familiar with it, what we call STROBE tools are available for these cross-sectional case control and cohort studies. CONSORT is a tool that's available to assess or to evaluate your experimental study. So what these tools do is they list the things that should be included in your study. So if you have a cross-sectional study, you can use a STROBE checklist for cross-sectional study, and you can go to the checklist and mark if you have addressed all those things. So through that process, you will learn that you should be able to do all of the things that we have discussed here. So I can drop the link to these tools. You can access them on Equator Network, which is a standard tool that's internationally used, and there are tools like for every research type, like even for qualitative research, for quality improvement projects, and every other thing, and I'm sure you'll find it useful. So saying that, single study, as we said, evidences a proof of consistency of finding across time and place. So a single study can never be used as an evidence. But you might be familiar with Bradford Hill's criteria. It's a criteria which we use for observational studies to assess if what we have found can be considered as an evidence or can be used as a cause-effect relationship. So if you see the criteria, there are a number of things which can be assessed in terms of the credibility markers that we have discussed here. But in addition to that, Bradford Hill's criteria recommends that for something to be taken as a cause-effect relationship or as an evidence, we have to demonstrate consistency of findings across place and time. So the place of demonstrating consistency across different period and time is very important, and we should not take that for granted. So how do we assess consistency among studies? So I think you can drop your answers. How do we assess? Now we said that from a single study to evidence, the bridges to confirm the presence of consistency among or between different studies. So how do we assess consistency among studies? Let me give you 15 seconds. You can drop your answer. Oh, okay, I just saw the question. Equator Network is the name of the site where you can access all tools. I'll drop the link at the end of the webinar so that you can look at the tool, the site yourself. So how do we assess consistency among studies? Let's say we have different studies. We want to assess repeat the study by other researcher. Yes, okay. Yes, so we have a number of studies conducted at different places at different time. So how do we how do we assess, how do we bring that evidence together and put it as a single evidence? Yeah, so let's say we have like 10 studies that are conducted in different countries and at different time. Great, meta-analysis, we predict, great. So we have what we call, okay, great, thank you. So we have what we call secondary studies. Secondary studies or reviews are studies which are conducted by gathering different primary studies. So primary studies are studies which are based on participants themselves. So we recruit data, we collect data from the participants, either directly from them or from their medical records, and try to see the presence of association between our exposure and outcome. But in secondary studies, our study units are other studies. So we're going to take studies from Ethiopia, from other African countries, from Asia, from Europe, stuff like that. And then we try to analyze if these studies have come up with findings that are consistent between this population and if it is something that can be used as an evidence. So there are two types of reviews. The first one is study of studies, or what we call review simply, and these are systematic review and meta-analysis. And the second is review of reviews, where in this case what we're doing is in the study of studies or reviews, what we do is we collect other studies, primary studies, and we study them together, and we try to see the presence of consistency across these studies. And in review of reviews, or what we call umbrella review, what we do is we gather a number of systematic review and meta-analysis, and we try to see if there is consistency between these studies. So these are the highest form of studies where we can say that we're getting closer to evidence. So by gathering these primary studies, someone can do a systematic review, which is simply a descriptive synthesis of results. And we will try to see if there is a pattern between in the findings of these studies that are conducted in different countries. So meta-analysis is different from systematic review in a way that it tries to pull the effect from different studies, and it tries to give us one single result from these different studies. So getting one single result is good because we can comfortably say that, let's say, different studies demonstrate that the risk of taking OCP on DVT is like 1.2 times, 3 times, 2.3 times over a different period of time and over different population. Let's say we have demonstrated these things based on these studies. So in meta-analysis, what we do is we will try to pull all these effects together and we come up with a single number. Let's say the risk of taking hypercoagulability among patients, among women who took OCP is like 2.7 times higher. So this is a single number that we obtain from these studies. And whenever we pull effects together in we call it, what we're doing is meta-analysis. So if we're not pulling the effects together, but rather we just narrate the results and we try to see if there's a pattern, we call it systematic review. So in umbrella review, what we do is we collect a number of systematic review and meta-analysis studies and try to see if there is any pattern between them, and we try to see if there is consistency in findings of systematic reviews that are conducted in different times and across different geographical location. So sometimes you might wonder why we need a further review, because some reviews can be conducted at an earlier stage, and after we have reviews like systematic review and meta-analysis, a new evidence can come up. I mean, a unique observation can happen, and we can keep studying those things using other primary studies. So when we have new evidences generated, someone can do another systematic review, and when there is again another new source of information, you can do another systematic review. So still, to get a higher form of evidence, we have to analyze these systematic reviews and meta-analysis so that we can have a higher form of evidence, which is synthesized based on these other source of evidences, which are secondary studies. So case report is a simple observation, and by umbrella review or systematic review or meta-analysis, we get what we call evidence. So at this point, we have demonstrated the consistency of finding across different studies, which vary based on time, person, and place. So we can comfortably say that this factor or exposure is associated with the development of this outcome. So we can comfortably tell our patients to avoid these things or to do some positive things like exercise is beneficial for your health, so you have to exercise. And we can even write those in our medical books and study them as a fact or truth or proof. So these studies, just like the primary studies, they should be assessed for their credibility. And the first one is whenever we do secondary studies, we have to make sure that we did a comprehensive search. Unless we do a comprehensive search and include all available primary studies, we can't say that systematic review is acceptable. So I mean, someone can purposely neglect some studies which has negative association, negative results. And if we're, as an author, if we're looking for a positive effect of a new drug on some outcome, let's say, I mean, from the perspective of someone who works at a pharmaceutical company, you can purposely neglect studies, primary studies that show that there is no effect of that drug on disease outcome, or there is a negative effect of that drug on disease outcome. You might neglect that. So to avoid that, we have to make sure that there is a comprehensive search has been made by different researchers, and all potential researchers are collected so that we can get the true effect of that drug on our patients' outcome by considering all studies conducted so far. So when we do the search, we have to make sure that we have acceptable eligibility criteria. That's not too shallow, that's not too wide, but that is within the framework of our research question. And we have to be able to select and extract data from these eligible studies. And the others, and a very important thing, is risk of bias assessment. I mean, even if the primary studies follow all protocol to make sure that they're credible, like based on the criteria that we have listed previously, still primary studies can make some mistakes that could introduce bias when we try to generate evidence. So risk of bias assessment is a very important step. And there's also a tool to assess risk of bias for every form of study. Again, if there's anyone who's doing a systematic review or meta-analysis, I can drop the tools at the end of the webinar, the link to the tools. So there are different tools. Let's say if you have a cross-sectional study, there's what we call the JBI checklist. So you have to use that checklist and assess that study for its level of quality, and you label it as low, medium, or high quality study. So these results has also be reported as part of the meta-analysis result, so that the reader can judge for himself or herself that the meta-analysis result is based on studies whose quality were like this. So some of them were low, some of them were medium, and some of them were high. And even our conclusion should be based on the quality of this study. So if we have a number of poor studies, then we have to be careful when we conclude our findings from these studies. The other is data presentation method. The commonest form or the most acceptable way of presenting our data is using forest plot, which I will show you later. And we have to decide, again, as I've explained earlier, you might wonder if if meta-analysis can pull effects together and give us one number. Why don't we do meta-analysis all the time instead of systematic review? Because everybody wants a single answer, right? Even in medical school, someone will ask, what's the risk of this exposure on this outcome? Tell me the number, right? So even our patients ask that kind of question. By how much is my risk because of this exposure that I have? So to give that single number is something nice, but should we always pull effects together or not should depend on a number of factors. So sometimes our studies could have a number of inconsistencies in them that makes us unable to pull them together. And sometimes the number of studies that we included in our meta-analysis are very small, and which makes it unfair to pull the effects together. So there are different models to pull the effects. We call them fixed random effect models. And when we try to use these models, we have to be careful, because if we have very few studies, or if we have studies that are very much inconsistent, then pulling the effects together will be unfair, and it will not give us an accurate result. So as part of this, we have to assess heterogeneity between studies. So if the studies that we're studying are like very much divergent in terms of their method, their approach, the tools they used and everything, then we should be careful. And we at some point we might even be forced to avoid pulling the effects together. So these are the things that we should assess. I think you might be familiar with I-squared statistic and other things that we use to assess the presence of heterogeneity between studies. And the other is what we call a very interesting concept, publication bias. When we do systematic review, we have to do publication bias. So systematic review, meta-analysis, umbrella review, for all reviews, we have to assess publication bias. And publication bias means some studies, like I said earlier, if they have undesirable result, like negative result or no association at all between the new drug treatment and the outcome, so someone might differ from publishing this results, because at a larger scale, probably what the sponsor is looking for is a positive result, so that that drug can be put into use into the market. So publication bias is something that's always expected to be present, and luckily for us, there is a statistical tools that we can use to see if there is a publication bias or not, and we can even fix those absent studies by using different analysis methods. So you might have come across with funnel plot, with stream and fill analysis. I'll also show you some research to see what these things are. So finally, after we assess all of these things and do our analysis, either systematic, meta-analysis, or umbrella review, finally, the evidence that we have generated has to be again assessed. Even at this point, after we pull our effects using these reviews, we have to assess the certainty of the evidence, and we call this a grade approach. So a grade approach, it's an acronym. All of these things are factors that we should use to assess the certainty of the evidence that we have gathered. So as you can see, from observation to evidence, it's a long process. It takes years, and it takes a number of quality work to reach there. And even when we reach to that single evidence that we have synthesized using different methods, we have to ascertain if this evidence is actually certain and correct and credible. So lastly, there are also tools to assess these secondary studies, just like on the Equator network, just like the primary studies. When somebody sends you like a meta-analysis or systematic review, you shouldn't frustrate because you're not familiar with the important components that should be included in the study. So you'll get all of these things on these tools. So if what you did is systematic review and meta-analysis, the proper tool to use is Prisma. So you can use the Prisma checklist and assess if the study has reported everything that's included, that should be included in a systematic review and meta-analysis. Moose's, you might come across this term, Moose's meta-analysis based on observational studies. I personally don't recommend this very much because it's not an open access tool, and the commonly used one is Prisma. But if you come across Moose tool, don't be surprised. It's also a tool to assess meta-analysis based on observational studies. And when you're doing umbrella review, the tool that you should use to assess if the umbrella review has included every relevant thing is called Priori. So Priori is also a tool that you can access on the Equator network. I'll share you the link as promised. So this is the journey that a single observation goes through different phases to become an evidence. So what's the role of clinicians in this? What's your role? What do you think is your role in this evidence generation process? I think most of you are clinicians. So what's your role? Most clinicians admit that I'm not a researcher, yeah, I'm not a researcher, I don't have any role in research, but even when great, critically appraised, the most important thing that we all forget is like clinicians are at the heart of this evidence generation process, because as we said, every research starts with an observation, which is unique, and it's our clinicians who treats patients on a daily basis, and these are people who can discover these unique circumstances. I mean, when we're talking about clinical research, right? For those of you who are leaders and in another form of research, like quality improvement research, still, yes, there is a place, but when we talk about clinical research, whether you are a researcher or not, clinicians are the ones who make the observation and report that it's unique. And the thing is, that's why most clinicians write case reports, but they stop there. I mean, they write some new finding, they communicate that through case report or case series, but they stop there and they don't go to the further process of evidence generation when large-scale studies are conducted. So clinicians are usually here, but I don't know, public health professionals or other people who are like engaged in research as a full-time job do all this work. So I don't know, whenever you treat patients and whenever you take good history and write that history, you're contributing for clinical research, even if you're not directly involved in the evidence generation process. Because most of our research, I don't know, 70–80% of our research are based on record reviews. We usually do retrospective studies. And a clinician who writes a very good history is contributing to evidence generation, because that's where we get our data whenever we conduct whatever you call it, like cohort, case control, cross-sectional studies, because we get our information from charts. So great. So I think what I believe is we have to contribute for research, not from just from the observation perspective, but with little exposure and with little reading, every clinician can become a very good researcher. And if a clinician becomes researcher, believe me, that's the highest quality of research can be obtained from clinicians, because whenever you find something, you know, contextualizing it in terms of the patients, the currently available practice, the guideline, it's very much easier for clinicians to contextualize clinical research findings than someone who doesn't see patients and sits in offices and do research. Especially people who are here, you'll be surprised. Researchers who spend most of the time doing these reviews are people who don't even see patients at all, probably people who have never been clinicians at all, but they do clinical research about new drug therapies or new medications, or like something that a clinician would be interested in and something that a clinician can explain better. So I don't know, I'm just trying to make sure that you all are interested in research. So before we go to the question and answer, I would like to show you something. Okay. You can see the screen, right? You can see the screen, right?
Yes.
Yeah, thank you. Okay, so this is a study on vaccine, COVID-19 vaccine acceptance among healthcare professionals. So this is a single study, a primary or original study. We're not going to assess its quality and other details. I just want to show you what are expected from primary studies and secondary studies. So this is a study among a group of healthcare professionals in some hospital using a cross-sectional study. So from these studies, what we expect is they have to be able to use the proper study design. They have to use appropriate or adequate sample size using the proper sample size calculation formula. As you can see, they have stated that they have used this formula by taking these values, because it's very important. that when they reach to a sample size of 440, they have to be able to show us that this 440 is a sample size that they have reached using the proper sample size calculation formula, and that the participants are selected using methods. As you can see, they have also explained about sampling technique and procedure, which we expected to be a probability sampling method. That means using a random selection process. So these two are certain, so we can be comfortable about the sample that's included. And the other is data processing and analysis. Our data has to be properly managed, and the proper statistical tools has to be selected, and the assumptions has to be tested. See, as you can see, they said model fitness was tested using this test, and the result was like this. So it's expected from each and every researcher to put the assumption test, model fitness test result, so that we can be sure that that statistical tool was appropriate to use a statistical tool for that specific data. And the other is ethics and everything. It's very important in any study. So when we present our results, we can present them using different methods, like as a table, as a chart, and everything. And finally, what these researchers have found is what they were studying is the vaccine acceptance. So yeah, so 45.9% of the participants were refused to take COVID-19 vaccine. So the acceptance rate is like 54.1%. So 54.1% was the acceptance rate. So this is a single study that reported the finding based on a group of individuals, which used a proper sample size technique and everything. So when we have a number of studies, similar studies about vaccine acceptance in Ethiopia, in different regions, among different population. Finally, when we have a pool of these primary studies, we can do a systematic review and meta-analysis. So COVID-19 acceptance rate and its predictors in Ethiopia. So somebody did the systematic review and meta-analysis. Here, what is expected is we have to do a comprehensive search, and we have to report everything that we used, because we can judge whether they have used comprehensive search or not. As you can see, they have also put the search strings, the search strategies that they have used on the different databases. So when you have, if you have these search strings, you can enter them into the databases, and you can see for yourself if the number of articles they have retrieved at the beginning is actually true or not. So it's usually presented using the flow diagram, the Prisma flow diagram like this. So we have searched the articles based on this method, and we have found this much. And then after we remove duplicates, we got this many articles, and we have found only 50 to be eligible, stuff like that. So this is a process where you show that you did a comprehensive search and no research is left behind, which is eligible. And the other is to put your eligibility criteria, and that you have extracted data based on the proper eligibility criteria set. The other is risk of bias assessment, or we also call it quality assessment. As you can see, there are using, this is systematic review of cross-sectional studies. So like I told you, they have used the JBI quality appraisal checklist. So using this checklist, they have assessed the quality of the studies. And supplementary file 2, I can share the link to this article so that you can see for yourself. So the quality of the studies has to be presented using a table, and we can see that if they were high quality or low quality. So meta-analysis, as you can see, yes, so they also did meta-analysis because they have assessed for different factors. So this is, let me skip first. These are the studies, the eligible studies that are included. As you can see, the study area, the region, study design that was used, all of them were cross-sectional studies, and the study population, the sample size, everything. As here, the quality is also reported. So all of them were low risk studies. That means good quality. So high risk, medium risk studies are studies which we should not feel comfortable to pull their results together. And forest plot is this. So using forest plot, the previous studies finding their prevalence of vaccine hesitancy among the different studies is put here. And finally, if we feel comfortable assessing different factors that these results can be pulled together, we can pull it using the meta-analysis. And as you can see, the pull effect is put here at the bottom. It's present as a diamond. So whenever you find a diamond in a forest plot, it means they have pulled the effect, and this is a meta-analysis study. So the pooled prevalences, now we have a single number to say that the COVID-19 acceptance rate in Ethiopia is 51.2%. So this is something that we have reached using a meta-analysis. We can also do subgroup analysis and others. And this is a funnel plot that I have told you about, a publication bias. So if we feel like this before pulling our results, if we feel like there are studies that are left behind due to different reasons, due to their negative reporting or undesirable report, or not interesting reports, we have to make sure that it's correct by using a funnel plot. So our funnel plot shows that there is a good distribution of papers on both sides, and we can be comfortable to say that there is no publication bias. So if there was a publication bias, there is a way to fill that gap using a statistical method, which if you're interested, you can study further. So one last thing is whenever we conduct reviews, if that review is based on experimental studies, other experimental studies, if the review is based on experimental studies, this is again a highest form of evidence as compared to reviews which are based on other observational primary studies. So the best form of evidence we can get is a review which is based on experimental studies. So this is all about my part.
Thank you very much, Doctor. So participants,